Thank you for joining us today. For our first session of this community practice, the role of health centers to provide primary care for justice-involved individuals. The session one is health risks and care needs during community reentry. Just a few housekeeping reminders. All participants are muted upon entry. And if you would like to participate, please raise your hand in the chat to unmute. Sorry, raise your hand or write in the chat to be unmuted. And if you could now let us know where you're joining from, your organization, and the work that you do. This meeting is being recorded and these slides will be sent after the session. This is a disclaimer that the National Center for Public Housing is supported by HRSA's award, and all contents of this community practice does not represent the official views or endorsement of HRSA and the U.S. government. So our speaker today is Dr. Kevin Lombardi. He's our Director of Research Policy and Health Promotion. And I'll let him get started. Oh, sorry. I am Jumoke Oladipo. I'll be your monitor for today. If you have any questions, let me know in the chat, and we'll get started.
Hi, everyone. Thanks for joining us today, and thanks for your service to your health center and your community. Let's start in the chat. Please throw in who you serve, how you serve them, where you serve, so we can get an understanding of our group. This is a community of practice, so we are going to be interacting with each other as much as we can through case studies and through the material. So put something in the chat. Also read the chat. Get a chance to know your colleagues. This is a national audience, so we have people from around the country doing your job in different places. So it's a great opportunity to share best practices and make connections, networking, so to say. Next slide, please. Just to go over the learning objectives for today. This is a four-session community of practice, and we're going to be following the same sort of format for each session, with different material, of course. I will have slides that will go over set research, data, statistics that indicate important things about this population. I will discuss those things, connect it to clinical work, and connect it to social and behavioral health work, and connect it to practice management. And we will go over case studies that probe deeper into that so we can understand the patient perspective more and share our best practices from our relative fields. The case studies are designed to touch different aspects of health center management, behavioral health, clinical practice, chronic disease management, program management, community health work, and social work. So that's to bring all of your information in so that you guys can all have something to say from your particular professional perspective. Today we'll be looking at some data regarding epidemiology of jail and prison populations. They are distinct in the context of the justice-involved population. We will identify the risks associated with the transition from jail or prison separately for the justice-involved community, and review case studies that look at different aspects of health in that transition: chronic disease, infectious disease, behavioral health, and substance use and abuse. Finally, we'll discuss some of the barriers that make it difficult to get these folks into the exam room and that emphasize the work that is needed during the initial visits. So I won't give too many spoilers, and we'll go to the next slide, please. Okay, let's see who we have here. We have a social worker. Oh, lovely. We have someone from Florida, from MCR Health. Welcome. Charter Oak Health Center, case manager, lovely. Health Services, LA, love it. CHW, lovely. Great. Fabulous audience. Let's sort of get into the numbers here. And let me just grab my notes. So these numbers are really big, guys. Justice involved individuals are often thought as a separate population. Uh, there are 1.2 million people, and this is just the folks that have been in a federal prison. 1.2 million people in the United States have are justice involved, or have been justice involved. That is a huge number. It's the largest in the world, and about 50% of U.S. adults have an immediate family member that has been in the justice systems before. Um, uh, the So as I was saying, we think of this as a separate population in the public health sphere because to a certain degree it functions as a separate population. So I want to sort of separate them out for a moment, but keeping in mind that this is contextual and that justice involved individuals are members of our community, as the second data point exemplifies. But from the public health perspective, jails and prisons represent two closely related but different populations because of the epidemiological dynamics that involve being in prison and the unique health risks and health factors that put this population at generally higher risk or of a range of outcomes compared to the general population. That perspective also allows us to focus on those risks and how they function structurally. But this group of folks is members of our community, and to sort of emphasize the impact that that has when someone leaves long-term incarceration and integrates back in the community. They are living with family members, perhaps. They are mothers, fathers, job seekers, parish members. The transition that they go through is present all around us, and our social systems is what allows folks to make that transition in a easier way and a safer way. It is genuinely requires both a community-based perspective and a population-based perspective. So I want you to keep those separate in your mind. Um, Thinking of the U.S. prison population as just in magnitude, it has grown rapidly over the 20th century, and I mean 5x in its population. Just to emphasize the magnitude, and again, this is the largest prison population in the world, is the U.S. prison population. Okay. I'm using some terms a little interchangeably here, and in general conversation, jails and prisons are from a dictionary perspective somewhat synonymous. From the perspective of public health and from the legal perspective, they are not. They are very distinct. And folks that transition from these facilities experience very different dynamics. Um, one, jails. These are short-term facilities run by local governments. They hold individuals for short periods, usually less than a year, and this includes arrests and pretrial holding. Prisons are state or federal facilities that hold individuals for long stays. That is usually more than 1 year. It can be, of course, much longer than 1 year, and this is typically for felony convictions. The Those released from prisons and jails experience, as you may imagine, very different challenges post-release, and it is important to make that distinction when providing resources to patients or when managing them as new primary care patients in the primary care context, in the health center context. In general, individuals who are released from jail short term experience less disruption just because of the length of stay, but this varies significantly. There is a sort of a Venn diagram of overlap. For example, someone who served a 5 year sentence versus someone who 5 week sentence versus someone who served a 6 month sentence. These are very different realities from just a disruption perspective. Now, if you take the same person in one stay or the other and give them the same collection of chronic diseases, say hypertension, behavioral health issue, let's say depression, and let's say substance use disorder as well, with no use in prison, and you look at someone who has a 5 week disruption versus someone who has a 6 month disruption due to a jail or prison stay, the magnitude is massively different. For our individual who's been out for 5 weeks, they may still have a place to live. They may still have a job. They are likely to still have health insurance. And the disruption is much more manageable, especially for our social workers and CHWs. It's a situation that allows much more focus. A 6 month sentence or something longer, a totally different reality. Folks are unhoused in most cases and have to live with a family member. It is very difficult to get housing because they don't have an income. And of course, they are not employed and unlikely to have health insurance. It's a much bigger load. The risk of them not following their physician and loss to care is also much higher. So it's important to to distinguish these two populations and to get across that that distinction has real impact on how you manage them from a social and behavioral and a clinical science perspective. So make the distinction when you are designing screeners or asking the questions. Anyway, now we're going to go into our subjects, and they start with facts to sort of anchor us in the reality, the epidemiological reality of the experience of justice-involved individuals. And then we go into our case studies and try to pull out some details and share some ideas. So, the post-release period is among the highest risk health transition periods in the U.S. population. Justice-involved individuals have 2 or 3 times the rate of concurrent chronic diseases, or 2 to 4 times the risk of all-cause risk of mortality of the general population. Their overdose risk is much, much higher, 3 times higher than individuals without incarceration exposure. And the window is not permanent. It's highest risk in the first 2 weeks to a month after release. Realistically, that's why when we want to see patients in the clinic, that's when we want to start helping them to manage these issues if they are present and be a loci of stability. Close follow-up is critical for individuals who have recently been released. For chronic diseases in particular, control of diabetes, hypertension, or heart failure, for folks who have those diagnoses is very different. They've spent years potentially under poor management, and typically their medications need to be changed. They need to be followed very closely, and that requires very good communication. For an individual who is transitioning back into the general population from a prison, in particular a longer stay, um, if you can provide continuity of care support and the patient's chronic diseases and substance abuse and or mental health diagnoses in particular are well managed, it produces a loci of stability that affects the rest of their lives. I use the term loci. It produces stability. It is one less thing that they need to worry about, one. And two, managing chronic diseases has a huge impact on energy, mindset, and motivation, period. If they're better managed, folks will be better from a psychological perspective, able to meet the demands that post-release puts in front of folks. Let me see if we're aligned on slides. We are. Next slide. Okay, so here's a first case study. I am going to read it and ask that everyone put their answer in the chat. It can be short, it can be long, it can have questions. I just want to hear your thoughts so we can start to string them together and answer questions and share practices. A 42-year-old man with hypertension, opioid use disorder, and type 2 diabetes is released from prison without medications, insurance, or a scheduled follow-up, and returns to unstable housing. Given limited resources, how would you prioritize his immediate medical and social needs in the first 2 weeks post-release? So, what are the priorities? Jump on the chat and put some bullet points. There are no wrong answers here. And Jamaica, I'll ask you to make some bullet points as well, if you've got some notes or something of the sort, because you will be my guinea pig if we don't have enough to fill the block. Limited resources. We have hypertension, opioid use disorder, type 2 diabetes, no medications, insurance, or scheduled follow-up, walks into the health center. Priorities. What are they? Yes, let's see. Okay. Benefits referral, meet with him, housing resources, connection to mental health for SUD, connect with PCP, have him speak with pharmacist. Yes, all across. Excellent answer. Stable housing, insurance, and schedule follow-up with the PCP. Yes. And social group, social support, 100%. And let's try to go through all of these and try to string them together. So I will say off the cuff, here would be my list for this patient. One, initiate treatment for opioid use disorder immediately. Start buprenorphine same day if appropriate. We can do it in the clinic and observe him and then send him home with that. It reduces his risk of overdose. This patient needs naloxone and overdose education. The 2 weeks post-release period is very high risk for overdose. So we need to make sure that he knows what those risks are so he can navigate them as safely as possible. And that naloxone is a lifesaver. Restart his chronic disease medication, right? Who knows how these have been managed? But in general, if was receiving things in prison, we want to start him at his dose, maybe change it. And I'm going to want to see him in 3 months and then 3 months after that. So 3 and 6 months to make sure his medication is meeting what his needs are post-release. For folks that are go from incarceration to the community and they have hypertension and diabetes, that's going to change their chronic disease as rapidly as it changes the rest of their lives. Their diet changes, their routine changes. This can have good and bad effects. Um, we heard a lot about navigation, uh, but we need to make sure that this person has a short-term supply of his medications and that he's networked to insurance for long-term provision. Uh, Rapid follow-up care, active community health worker support. This is an individual that would really benefit from a coaching style interaction with a community health worker. In many of you that you may do this in your careers, but this is an individual that would want to see a CHW longitudinally over 6 months, and that CHW would be able to work on those priority areas for us. And what we see is as we in the exam room are working on those chronic diseases, the social worker and or community health worker is working through those individual barriers with the patient and helping them to integrate. These things work together. They weave like a fabric. And the housing's instability, of course, identify temporary shelters or house supportive housing options when available. This is when your social workers are the most popular person on the team because those are difficult resources to find and require very intense knowledge of local housing stock and resources. Also to remember is those behavioral health needs. Assess for depression, assess for anxiety, assess for suicide risk. The post-release period is also a high period for suicide ideation for depression and for bad bouts of anxiety. And of course, transportation. We want to make sure that our patient can get to the office and that we don't lose him to care. We got him the first time, but that second follow-up is almost as important as the first one. We want our clinic appointments to have a beat to them. Bam, 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 bam. We don't want to miss a beat or the song doesn't sound good. So I see. So I know we have some CHWs um, in the crowd. Um, so I'm wondering, Kristen, if I could ask you, you mentioned benefits referral first, housing resources, mental health from SUD. Can you speak to any resources that are available in your area that you would want to make sure this patient has first?
Sure. So at our company, we have a benefits counselor as far as for housing. It would depend on the situation, but if they're looking for shelter, we have connection to coordinated entry. Otherwise, non-coordinated entry also. We have community advocates, calling 211 social service phone number. Milwaukee Rental Housing Resource Center. Um, there's quite a few different resources. It kind of depends on the situation.
Hmm. No, Kristen, I'm sorry I didn't ask you. Could you give the group like a quick intro and who you serve and how you serve? I heard Milwaukee, but I'd love
Sh
to know some more about that.
Sure. So I'm a primary care social worker at a federally qualified healthcare clinic.
Mm-hmm.
And so I'm the sole social worker for primary care, the Medical College of Wisconsin residency program.
Mm-hmm.
Um, and so what I recommended was just, trying to get the individual connected with various services. Um, yeah, and as far as for mental health, sometimes there's a wait for that, but we do have access services that patients can um, do like a walk-in service for that until they can get connected with a therapist or psychiatrist.
Mm. Fabulous, fabulous.
Mhm.
I'm wondering, in your circumstance, when do you find out that an individual is recently justice involved? Say they were released from prison or a federal prison.
Typically, upon the first visit, say if it's a new patient coming to the clinic, after the patient meets with the doctor, um, and the medical assistant does a screening for certain SDOH, social determinants of health, and then a
Mm,
referral is generated, and then I would reach out to see if that individual wants to meet to talk about resources and whatever their needs would be.
hmm
Mhm.
Well, Kristen, firstly, thank you for doing what you do and serving your community. Secondly, thank you for finding our first promising practice. It's like there's I have them buried in the slides, and you found one. That's an excellent screening system that you guys have there.
Mhm.
Fabulous. It is very difficult to miss this. Making sure that you grab it early is the difference between getting those resources early and not. And your system allows you and your colleagues to intervene early when the patient's at greatest risk of loss to follow-up. The key aspect that is replicable there is the screening and the upstream medical needs, medical social needs. SDOH are various terms for this tool that is used. I recommend either the Prepare or the Well RX screen. Making sure there is a good social needs assessment in the beginning is the difference between catching this and not. So for those of you, and these screens are used in various ways. Health centers they've been very popular in adoption in the last 3 to 4 years in particular. But if you don't have a screen that is catching this, when the patient signs papers in the beginning, when they are doing their intake, make sure there is a tool to do it. It doesn't necessarily need to be through a SDOH screen. It can be through their intake paperwork or attached to other screens, but make sure you have it. And I'll give a sort of an example why. The patient goes through their first visit. They that is not identified at the visit. It makes it very difficult to actually treat the patient clinically and non-clinically the way they need to be treated. It's like missing a diagnosis in a way. So make sure you catch it early. Thank you, Kristen. Next slide, please. Incarceration, chronic disease. Approximately 40 to 50% of incarcerated adults in the US have at least one chronic medical condition. Rates of hypertension are particularly high, at 30% higher than the general population, and asthma prevalence is nearly twice as the general population. These two in particular are among the highest differences in chronic disease across the studies that I examined, and they're there for a reason too. Prison is stressful. And the ventilation is bad for years. This deeply impacts folks' lungs. This deeply impacts their circulatory system, and it makes them much more likely to develop chronic disease if they don't have it, or for that chronic disease to be more severe. So, when you have a justice involved individual that reconnects to care and has hypertension, diabetes, and so forth, you need to be very careful when you examine those lab values and you examine that patient because they are likely to be at higher magnitude and they are likely to be at high risk of advancement as well. These are things that need to be identified early. Next slide, please. Cervical cancer. Here's some other ones that are just, mind-blowing, and emphasize the importance of what we should be focusing on. Cervical cancer, 4.16 times the general population. Arthritis, 1.65 times the general population. And hepatitis, 2.57 times the general population. Of course, this is an infectious disease, but about 75 to 85% of folks with hepatitis present in the chronic state. Next slide, please. See, I'm gonna manage here. And smoking. In general, I've seen the EHRs. Did you ask the patient about smoking? Click. Very easy to do. Is that always asked? Who knows? There's 15 minutes in those appointments, and it's very difficult to get through everything. If it's asked, it's not asked in a way that's going to take up a lot of time, and it's best to take the smoking screening and replicate it outside of the exam room. Make sure that you're asking it before the patient gets to the physician and allowing folks like nurses, community health workers, behavioral health workers to take more of the responsibility in talking about smoking and implementing that into their work is also incredibly helpful as well. In my experience, they tend to be better about having these conversations and tend to know the resources better as well. So make sure that's being asked and the referrals are being sent. And of course, justice involved individuals experience chronic disease 10 to 15 years before the general population. It is it's a testament to the stress of the prison and jail experience and the fact that it often continues after they leave. Ooh, excuse me. Next case study. Now we have a 34-year-old female who presents to a community health center 3 weeks after release from incarceration. She has no primary care provider and is not taking any medications. Her history includes hypertension and tobacco use. She reports fatigue, regular menses, and has not received routine medical care in several years. Okay. What are your priorities? Pop it into the chat. What are the most important priorities to address at this initial visit that reduce her long-term health risk? Same system as the last one. Please put your thoughts in the chat because we have a lot here with this patient. Any thoughts? What comes to mind? Yeah, nailed it. You got the GYN referral immediately, 100%. That was sort of the very high yield here. I just went over a couple of slides. One of the statistics that carries over, the rates of cervical cancer are 4 times the general population. This patient has irregular menses. She needs to be referred to a GYN and to be checked for a variety of different high-risk conditions, including cervical cancer. Um, and the fact that she had not received routine medical care is essentially anonymous to no active pap smear. So that's very, very high priority. And the smoking cessation as well, 100%. I'm going to go through my list and say continue with your own. But I just want to be comprehensive here, because this sort of patient is a type of patient that you will see. So one, of course, reestablishing primary care. We got them in. We've got to make sure we come in again. This patient needs full history, vitals, medication history, preventative care gaps need to be addressed, and there needs to be a way to communicate with them that is effective. Um, the patient's hypertension management needs to be reinitiated. BP confirmed, initiate or resume the therapy as it was. We want to address the tobacco, offer nicotine replacement or pharmacotherapy today. Initiate the preventative women's health screening if you can at your health center, not the referral. Pap smear is the plus. STI screening, HIV screening, and pregnancy tests for the irregular menses. Next slide, please. Infectious disease. Um, okay. So, one of my favorite topics. It's hard to be excited about it, but it's a fascinating topic. And with this population in particular, the risk for a variety of diseases is significantly higher than the general population. Um, Also, testing is not regular, and in general, patients are not tested for HIV or HCV in when they are discharged into the community. So here we have incarceration and infectious disease. 21% of state and federal inmates report having an infectious disease. Hepatitis C rates range between 10 and 20% compared to 1% of the general population. That's a 10 or 20x. That's a huge difference. HIV prevalence is approximately 10 times the general population. These patients need to be tested. Do not expect that they have been tested when they have been transitioned into the community. Data shows us that the majority of state and federal prisons do not test when they transition someone into the community, and the majority of folks are not who do have HIV are not discharged or not sent into the community with a referral. So this is a very high risk period for these individuals, and making sure that they get the appropriate care quickly is immensely important. Next slide, please. See if I'm coordinated here. I am. Okay. Made good use of the clip art for this one. So other infectious diseases as well. Tuberculosis, 4 times to 6 times the general population, with some studies indicating rates as high to 20 to 30% in some facilities. Rates of syphilis, gonorrhea, and chlamydia are significantly elevated. In general, this population benefits from early screening post-incarceration. Next slide, please. Okay, let's put this infectious disease stuff into a case study. 29-year-old male presents to a community health center 2 weeks after release from incarceration. He has untreated hepatitis C and has been off his asthma medication since release. He has no insurance, no medication, and no follow-up care in place. What are the most important immediate steps to address his health needs and prevent gaps in care? Jamoke, does anything pop up for you? Just one. What comes to your mind first when you see this patient? Immediate steps. I need to do this.
Medication to treat his hep C.
100%. 100%. 100%. Anything else?
Mm, insurance. So most likely has not seen a PCP as well. Um, Also asthma and medication.
Hmm. Hmm.
Maria said PCP as well.
Yeah, there are a variety of different things that need to be built behind that as well. One, this patient was released from incarceration. We don't know. But say it's 2 years. What is he unlikely or not to have? What is he unlikely to have when he presents to you after 2 years in incarceration?
History, a chart. Um,
He might be a new patient, but and he might have been referred or just walked in, but how about his payment for the services?
Insurance. Yep.
He's very unlikely to have insurance. When folks transition into the community, they don't get public insurance. They don't sit with a community health worker before they go. So this individual has no insurance in most circumstances. Um, so the first thing is identifying that and getting that patient enrolled or reactivated. So in some cases, and this is dealt differently at different health centers, in some cases that patient can be seen the same day, and the visit can be billed when the insurance is cleared. In some cases, they will need to get him back for when the insurance is cleared. It's going to be different at each health center, and you need to know the difference, and you need to make sure that the patient continues with his care, regardless of what it is. But making sure that his insurance is active is a core step that stops the rest of these from happening if it doesn't happen. Um, so, of course, restarting care after that is addressed and assess the immediate clinical status. There's a lot that needs to be done here today. First, the asthma management. Asthma is a very dangerous condition, and we want to make sure that he has an albuterol inhaler and that he has an inhaled corticosteroid when he leaves this office. Those things are easy to stock, and samples are usually provided. Um, his chronic disease medications need to start. He needs to leave with a supply if he can. Again, samples if available. Um, Confirm and stage his hepatitis C infection. Excuse me. That's usually via a HCV RNA, a lab test, liver function tests, a fibrosis assessment with ultrasound that can sometimes be done in office, and a linkage to treatment pathway kind of goes through that depending on severity, what the positives are. For those of you who have ultrasound or providers with ultrasound at your facility, that makes that much easier. They can just use a point of care ultrasound to check. Oftentimes it does require a formal ultrasound, but it certainly helps with the staging for a patient who's just walking in. The coordination and support. another individual that's a perfect match for a CHW, or in particular in a care navigation relationship, for follow-up access for the insurance, employment programs, whatever other non-clinical needs are manifesting themselves. Um, and I would say other things that are particularly high yield is the public health education, making sure the patient is understands asthma management and how to use their medications, go through asthma training, trigger avoidance, and so forth. Um, and establishing a continuity plan, whatever the next steps are for that HCV treatment initiation, in particular if there's a specialty referral that's involved. Next slide, please. Substance use and behavioral health. Um, as few as 15% of incarcerated individuals who have needed addiction treatment have received it. Over 50% of incarcerated individuals have a DSM-5 disorder on the books. Uh, and 17 to 24% of the incarcerated have a serious mental illness. Um, and that's just the folks that are diagnosed. This is many times higher than this is significantly higher than the general population. Um, Also, since we were just talking about insurance, important to note that of these individuals with these diagnoses, 90% do not have medical insurance when they leave incarceration. So it's very difficult to deal with mental health disorders when you are on medication. If you haven't received medication and don't have a way to get it, or your medication was provided in prison and you no longer have access to it, and you were just released into the community, that makes the transition incredibly difficult for folks. It raises the risk, it raises baseline stress, lowers motivation, and in general, raises their risk of a number of bad outcomes, including overdose, suicide ideation, and suicide attempt. So, behavioral health is incredibly important for managing justice involved individuals. And if I were to give you a couple of core elements that should be integrated if they're not, I would say one is early screening, making sure that those diagnoses are identified before the patient gets into the exam room, and that a chain of events is initiated when that screening is done, so that referrals are sent to behavioral health, referrals are sent to community health, or whoever is available or typically manages linkages to care for behavioral health at your health center. Two, initiating treatment immediately. And three, continuity of care, making sure that, and I will say, an additive benefit of behavioral health involvement, added benefit of CHW involvement is that it helps that continuity of care. In particular, if CHWs, in many cases, they're doing at-home visits for folks because phones cannot be relied upon for those individuals, or they're doing calls, they're doing regular check-ins with the individuals. They're the ones making sure they show up at their appointments in many cases. One, to emphasize the strength of that connection and that CHWs will help get your patients into the exam room. And two, the importance in this context. For folks with behavioral health and substance abuse issues, in general, they are high priority. But if they're transitioning from prison, even higher, even higher. Next slide, please. Okay, so let's throw this into a case study. A 31-year-old male presents to a health center one month after release from incarceration. He reports poor sleep, difficulty concentrating, and occasional substance use since release. He has not established care, is not taking any medications, and has missed a prior appointment. My question for you, What factors may be contributing to this patient's inconsistent engagement with care? How are you going to address it? Let's wait a minute. Let's put some thought, throw something into the chat. What comes to mind for you? Why is this patient inconsistently engaging? What can we do? So I'll give my perspective. There is really only so much you can do in the day. Um, we all wake up with our plans. I usually write down a checklist of what I need to do during the day, the night before, or during the day. And as I'm going through my day, I'm making my checklist. And it's amazing how much you need to do even in just a normal day with no stressors. Just a normal day with no diseases, with no addictions. That's it. Now, I have a stable life and I'm able to do that. Most of us have lives like that. They may not always feel as stable, but compared to these patients, they are incredibly stable. For someone who's transitioning from incarceration, there is a lot competing for the limited time that they have when they are going through one of the most severe adaptations that they've ever had to do in their lives. It's almost unreasonable to expect them to get everything done. So I will say, oh, I like that. Trust. Need to take small steps in transportation. Yes. Trust is in many ways a medical intervention. And I will say that, I don't want to keep mentioning community health workers because, they're amazing, but there are other ways and other individuals that can be high contact with these folks, including our behavioral health individuals and professionals, our social workers, clinical nurses, and case managers. You are seeing these folks in many ways, in many cases, the same way as a CHW does. But to emphasize that each of those interactions you have is an opportunity to build trust in a system in which there is likely no existing trust. When you build that trust, you kind of build a encouragement engine that stays with people, and will continue to push them to make better choices, to be more independent, and to manage themselves and their lives better. 100%. So trust, love that. Build trust with all of your patients, but these patients, you're going to see a lot of impact of that trust. Um, Unconditional positive regard. I love that too. 100%. Yes. And this is good advice for just treating people too, treat everyone the same, 100%, and treat all of your patients with kindness and regard. 100%. But also be focused on the specific needs of those patients. And kindness can be expressed in a lot of ways. It can be expressed through how you treat someone with your body language, how you speak to them, your eye contact. It can also be expressed with how you think about them as well. And making sure they are networked and ready to go and prepared is one of the kindest things you can do to someone who is in this situation. So I will say 100%, but put that kindness everywhere and turn it into action, which, looking at our audience, I know you all do for a living. So keep it up and take those words as encouragement for yourselves as well. But to kind of go over the big ones here. So the thing that helps me to understand this is the competing with time, right? Housing, finances, daily survival needs, this appointment are all competing with each other for this person's bandwidth. And when I see that, I see, okay, we need logistical support, social behavioral health, in particular. Two, substance use and risk of ongoing relapse is very high on my priority list as well. In particular, a screen for substance use disorder and an offer of same day treatment if available, or same day treatment. Sorry. So the untreated behavioral health conditions. This patient mentions poor sleep, Impaired concentration is described. That tells me that we're likely dealing with something that's behavioral health related, such as anxiety, PTSD, screen and initiate. That's what I see from that. Lack of care continuity. This is our biggest challenge today. It's also the thing that is the most under our control. Um, in general, and this is something that you realize very early in a healthcare career. There is only so much you as the provider or you as the professional control. People ultimately make their own decisions to show up, to take a medication, or what have you. You can't sit there and do it for them. And some of us deeply want to be able to bridge that and to just do that as providers, but that's just not reality. Um, the thing that you can do is to set someone up for success to make those decisions themselves and to raise the likelihood that they will make those decisions. And care continuity is the thing that we have the most control over. We may not be able to make them show up, get in their minds and make them walk in, but we can arrange transportation. We can send reminders. We can have someone show up in person if they need to, which in many cases for recently incarcerated folks is a good decision. Because their phones can be unreliable. They can miss those appointments just because it's hard to miss anything if you don't have a phone. Provide that support. And when you do, watch people flower. In particular, if you're in case management or you're working in behavioral health, you're going to get to know these people. Their lives are very emotional in many cases, and you will have the opportunity to connect to that. Um, in some ways, providing this support is like if you garden and you have a plant that needs a certain environment to survive, and when you're doing case management, when you're doing patient reminders, you're pruning that plant, you're watering that plant, you're fertilizing that plant, and the plant is doing the growing. You're not doing the growing. So I like to think of the relationship like that because it emphasizes on what is your internal locus, what do you control, and what is your external locus, what don't you control. If you put focus on what you can control and you do it well and you do it structurally, you give your patient the best chance to flower in this new phase of their life. They just got out of prison. Folks are likely looking around, feeling like they've been left behind, that things have changed. They're likely dealing with existing stressors from prison that aren't around anymore, but are still there in their minds. That's a lot to deal with for a supercomputer. That's too much for a human to deal with. Everything you do to help makes that easier and makes it more likely that they'll be able to have a good outcome. So, what I'll say is, uh, I guess I did say everything I needed to, but um, structure is important, and structure is kindness. Remember, structure is care. Um, anyway. Missed appointment reminders. We need a reminder system and a closed loop for follow-up and active research, including showing up at their house if you need to. The barriers to transportation are very high yield, a high impact as well. Phone access, insurance access, um, uh, trust in low health system trust, and I know one of our colleagues recently mentioned that as well. Um, trust improves engagement long term, period. Uh, we're also dealing with some potential cognitive difficulties as well, just because of the complex situation. This patient is having difficulty managing their appointments, and they need help with that, period. Okay, so we're running out of time. I'll get to the next one. Next slide, please. Okay, short-term jail stays and public health surveillance. Again, jails short-term, prisons long-term, just to simplify it. Um, this study looked at jail stays in particular and found that only 7% of surveyed prisons performed HIV screening, only 5% provided their hepatitis C screening, and only 9% provided PrEP to patients who requested it. Um, just to emphasize, if your patient has been in jail or has been in prison, do all the tests. Test for all the diseases, all the above. And I'm being glib when I say that, but in particular, HCV and HIV are extremely high priority for these patients. We don't want to miss an HCV or an HIV diagnosis. There are assumptions. If you ask sort of your average person or average provider who doesn't know these details, or do they typically screen in prisons or in jails? You'd be surprised how many people will say yes. There's an assumption that that thing that is done in prison, that is done in jail. It is not in many cases. So make sure that you do it at your health center, your own records there. Um, so anyway, next slide, please. One more case study. I'll read through this because I really like this one. A 26-year-old female presents to a health center 1 week after a 10-day jail stay. Prior to detention, she was being treated for a psychiatric condition and was stable on medication. Since release, she reports increased anxiety, poor sleep, and difficulty concentrating. She missed a scheduled follow-up appointment and felt like she did not feel like herself since returning home. Red flag. What is the most likely reason for her clinical deterioration, and what is the first step in stabilizing her care? My own perspectives here, since we're short on time. So one, uh, most likely reason for deterioration, this patient looks like they haven't taken their medication since they left prison. They were likely receiving it in prison and haven't received it next since they've gotten home. So that's the first fix that's going to make a difference in my opinion. Post-release stress and instability and possible withdrawal or rebound symptoms as well. So the first steps are medical insurance, uh, confirming diagnoses, and ensuring that this patient can start medication as soon as possible. Again, what did she take when she was in prison? Make the medication list, restart things as needed, and engage in very close follow-up. Again, post-incarceration is very different from incarceration. Folks are likely going to need different doses, but that titration takes time and close monitoring. And insurance is the way to get that to happen. And I'll say we're at 1:58, so I'm going to throw the ball over to Chimoke and ask her to wrap things up.
All right, thank you, Kevin. We're coming up on the hour, so we do not have time for Q&A. But if you have any questions, our email's at the end of the slides. And we have upcoming sessions as well. We hope that you will complete our post-evaluation survey that will come up on your screen after the end of this session. It lets us know what we're doing right, and we can keep giving you these trainings. So thank you in advance for your completion. We
So
hope
I
that,
will say this: I'll read these very very careful.
yeah.
So, and I'm not saying this like I'm watching. What I'm saying is, if you want something else, or you want a different approach, or you want different material, let me know. I will put it into the material.
Yep. And then speaking of material, our upcoming sessions, there's one next week, April 6th, and 3 and 4, the 13th and the 20th at the same time. Same registration link. So if you have colleagues, if you'd like to send that to, so they can join us as well. This is our contact information. And once again, the recording and slides will be made available after this session. So thank you for joining us. Have a great rest of your day.
Thank you.
Thanks for your service, guys. Keep up the good work.
Thank you.
Bye, everyone.